Hello, my name is Dominique DeBija, and my presentation is on special considerations for older patients in the emergency department. Emergency physicians are often the first healthcare providers to see patients seeking medical care, and with the growing population of older patients, emergency physicians can expect to see even more. In the United States, the percentage of people aged 65 and older is expected to increase by 147% from the year 2000 to 2050. For comparison, the percentage of people younger than 65 is expected to increase only by 49%. Within the group of older patients, there is also an increasing percentage of people aged 85 and older. More specifically, the size of this group is expected to increase by 388%. The number of visits to the emergency department has also been increasing. In 2002, the number of visits per 100 persons was 10 higher in older patients than in the overall population. At the same time, the country is seeing an increase in the prevalence and severity of comorbidities. This means that more and more patients will have multiple chronic conditions that must be managed concordantly. The diseases for which patients seek care in the emergency department and the causes of death vary by age. The older population, as depicted by the chart on the right, is more likely to die from a medical condition that requires hospital admission, indicated here by warmer colors and being led by heart disease and cancer. Older patients are also more likely to suffer an acute exacerbation of a chronic condition. In contrast, younger patients are more likely to seek emergency services primarily for trauma and surgeries, indicated here by cooler colors and being led by unintentional injury. There are 5 specific factors that impact diagnosis and treatment of older patients in the emergency department that we'll discuss one by one. The first is normal aging versus clinical disease. Many signs and symptoms of disease are often attributed to old age, leading to late diagnosis of potentially severe diseases. Conversely, inappropriate diagnosis and testing are sometimes performed for changes that can be attributed to physiologic aging, such as changes in creatinine clearance. When a patient comes to the emergency department, it is important for physicians to know what is physiologic and what is not. Next is polypharmacy. An older patient presenting to the emergency department may have an extensive medication list filled with prescriptions that they may or may not be taking. These patients are also at risk of leaving the emergency department with additional medications that they must remember to take and that may cross-react with their existing prescriptions. The population of patients aged 65 and older accounts for 12% of the population, but 41% of prescription drug use. From 1988 to 2010, the number of older patients taking at least 5 medications tripled from 12.8% to 39%. The same medication may affect patients differently based on age, such that older patients tend to suffer worse side effects. Reasons for this include changes in absorbing, metabolizing, and eliminating medications, as well as memory impairment or vision problems which complicate adherence to complex medical regimens. A study of patients aged 94 years and older in Switzerland found that most emergency department visits by this age group were due to falls and fractures, and that polypharmacy was an independent risk factor for fractures. Adverse drug reactions also tend to be reported as new complaints, including sometimes psychiatric complaints. And instead of looking to stop the offending medication, physicians may instead write a new prescription to treat the new complaint. This can lead to more adverse events and perceived new complaints. As mentioned previously, older patients have changes in drug clearance and metabolism. This is a normal physiologic decline in renal function, but it is very important to remember in order to adjust medication doses for older patients and minimize the risk of toxicity. Presentation of illness. Because many patients attribute their symptoms to growing old, they delay seeking out treatment and often present to the emergency department with later stages of disease. Studies show that older patients who sought treatment in the emergency department were more likely to have a higher percentage of visits classified as emergent and urgent than their younger counterparts. At the same time, due to normal physiologic changes, older patients' bodies react differently to disease and lead to unusual presentations of potentially common illness. For example, older patients can have a decreased ability to mount an appropriate immune response to an infection, and a lack of fever may mislead a physician's differential. As stated previously, the number of chronic conditions an older person has is increasing, and these comorbidities may also mask serious illnesses, again delaying the patient's presentation to the emergency department, as well as the physician's ability to correctly diagnose them. Functional status. Maintaining independence and quality of life is particularly important for older patients. Emergency physicians must be able to assess their patients' activities of daily living and instrumental activities of daily living, both to ensure that treatment options address these goals, as well as to determine the severity of the patient's illness during the workup. Finally, communication. Older patients may have difficulty expressing themselves due to factors including cognitive impairment, confusion, and dysarthria. An acute illness may also worsen a patient's existing cognitive impairment, increasing the difficulty of communicating and determining a diagnosis. For patients who come into the emergency department acutely ill or severely injured, there are some additional considerations. First, while age may play a role when determining the best course of action, it alone is not a contraindication to diagnosis and treatment. Emergency physicians should also be aware that older patients may have an advanced directive that should be reviewed as soon as possible. The patient's baseline functional status, as mentioned earlier, is particularly important in critical situations to both determine the impact of the disease on the patient, as well as to estimate prognosis and success of treatment. Medications should be reconciled as soon as possible so the physician can best understand what the patient is taking. In addition, when thinking about prescribing new medications, physicians should avoid drug redundancy and instead determine if they could actually decrease the number of prescriptions. Transfer documents and ambulance reports can be uniquely beneficial to emergency physicians, especially in patients with cognitive impairment or other reasons for which they may have difficulty communicating. Finally, a multidisciplinary team is particularly beneficial to the patient as well as the physician, since this will not only help diagnosis and treatment, but it will also aid disposition and ensure that the patient will be well cared for outside of the hospital, minimizing the risk of a return visit. I hope this talk on special considerations for older patients in the emergency department will help you help an older patient. Thank you for listening.